Good morning, good morning. Welcome to our 7:45 session, Delivering CF Care in Low and Middle Income Countries. Everyone, please continue to get your breakfast, get some coffee. We're going to get ourselves settled while we kind of talk through the presentations that are coming. Our NACFC presentation disclaimer. Myself and Kathy Mims are your moderators today. These are our disclosures, which just include grant funding. We have some amazing learning objectives for you all today. So we are going to compare and contrast the diverse experiences of a patient, U.S.-based trainers, and local healthcare providers while working to improve CF care in resource-limited settings. We're going to summarize the approaches utilized to equip care providers in low and middle income countries to improve the quality of CF care delivery and outcome evaluation. We're also going to report the methods to navigate complex medication procurement systems and establish a reliable system for essential therapies in low and middle income countries. So this is a discipline group. So the format is a bit different. We have our introduction, as you can see now, but then we're going to have 5 15-minute presentations. Our presenters are listed here, and then we will have a 30-minute Q&A panel at the very end. So I'm sure you all have seen the Q&A within the app, so feel free during the presentations to throw your questions in there. We will not forget them, and we'll try to get to as many as we can at the end. We also have 2 microphones that you can stand up for the Q&A and speak into. And with that, like I said, please feel free to get up and get breakfast and coffee as you need. And I think we are about ready to get started. So one moment.
I'm first. Okay. Should I? Yes, I'm first.
All right. We will begin with Dr. Samia Nasser. She's a professor of pediatrics at the Cystic Fibrosis Center at the University of Michigan, Michigan Medicine. She graduated from Ain Shams University in Cairo, Egypt, and she completed her pediatric residency at the Children's Hospital of Michigan in Detroit, Michigan, and then her fellowship in pediatric pulmonology at the University of Michigan. So she's been leading quality improvement efforts at the University of Michigan and is the physician lead for the CF Learning Network and the Success with Therapies Consortium. She also started quality improvement efforts with Marmara University CF in Egypt to improve the care, Marmara University CF Center in Turkey, in Istanbul, Turkey, and then has several universities in Egypt to improve their CF care. She's certified research coordinator and has been conducting clinical research for over 20 years. She has been publishing widely and presenting her research nationally and internationally, and she is my center director, so here is Samia Nasser.
Well, good morning. I'm glad that you're all here, bright and early. I wore a very bright suit so I can wake you up more. So, all right, so I'm going to be talking about my work mainly globally, but focusing on Egypt as well. So I work with the CF Foundation. They actually fund my work in Turkey and in Egypt, and the Middle East CF Association as well. So there is a significant disparity in low middle income countries in CF. We all know that. We were always focusing on the US, CF in US, but now that they're doing much better, and now we know that CF exists worldwide, we are really trying to work on this. So there is a lot of groups in this room and other places as well that are very focused on that. So CF is a global disease. There is lack of access to timely diagnosis, which is really important. And we saw that in Egypt where, okay, we don't have CF in Egypt because we're not testing. And so once you start testing, then you find it's there. lack of specialized care team, lack of CF medications, and lack of patients registry. So building the block for improving global CF care, we really need to work with, we are very interested in the U.S. A lot of people come to me and wanted to work in global work with me as well from other universities. So we all are very interested, but you really need to know what you're doing. So you need to acknowledge, you need to work with a team in a country that, gonna work with you. So we have lots of examples of that. We need to make sure that they acknowledge that the CF exists. We need to have the timely diagnosis. Training and education is really important. Okay, so we diagnose CF, and I'm using Egypt because it's like the one that I'm working with a lot more now. Okay, they believe that CF exists, but can they diagnose it? So they have to have the sweat testing. They have to have the genetic testing to be able to go on with that. And then once they have that, can they treat CF? So I know a kid with CF, but can I treat the kid? So it's very important to train the people there to be able to know how to treat CF. And then data collection is very important. So, and this is one of the things I'm really focusing on for this coming year, is to try to get a registry in Egypt. Turkey did very good. They are connected with the European CF registry. In Egypt, we still have to work through lots of different things. Creating multidisciplinary team, access to essential medications and therapies, and that's through advocacy to advice to the Ministry of Health. And then access to modulators, of course. So in Egypt, at the beginning, they really didn't, I graduated from there. So we were always told CF doesn't exist in Egypt. Learn about it as an interest, but you're not having it here, don't worry about it. So we did a study, and it was published in 2007, and the study was mainly focusing on, we tested a lot of patients in a clinic, and there was lots of them that have CF. So we published the paper, and since then, they believe that CF exists. There were papers before that by geneticists, but it wasn't taken, it didn't click with them. This is one of my patients, and by the way, I have verbal approval from the parents and the patients for any of the pictures I have here. So Yusuf was one of my first patients I've taken care of, and this is at 1 year of age, the picture to your left. And he was malnourished, he was really in bad shape, and at the time there was no enzymes in Egypt. I would bring enzymes with me, especially for Yusuf, and medications and things like that. He lasted till about 10 years of age. You can see the picture on your right. He's steroids, a lot of steroids, and also he was more nourished and doing better in that sense. But he lasted till about 10, and I remember when he passed away, it was heartbroken to me. The timely diagnosis, so we have 2 ways you can diagnose CF. In the US, we always use the macroduct, but some countries are using nanoduct, and in Egypt, I know they had it, and we switched to macroduct. It can be used, but it's a screening, then you have to really confirm it with the macroduct, and I'm gonna just skip that. The CFTR, we have CFTR panels, and then if that's positive, 1 mutation or positive sweat, but no mutation, then you can go to the sequencing. These are patients through collaboration with the Middle East CF Association, we were able to get 4 sweat testing equipment in 2000 and during the pandemic, and we did a lot of the teaching was done, a lot of it through virtual. But in a meeting, we had patients with CF. They brought the patients to the conference, and we're able to teach other centers how to do the sweat testing, which is really important. This slide is showing mostly the mutation that we have in Egypt. It's through work, through the CF, the people taking care of CF patients in Egypt will do the panel first, which is about 30 mutation, and then we were able to send it to the Czech Republic, to the Charles University. Excuse me, one of my colleagues there were able to do the sequencing for all of them. And we found that, a lot of the patients there have delta F508. So it's about 50%, 58% of patients with mutations with the delta F508 mutation, which is very interesting, and it's different than Turkey, it's different than other countries in the Middle East, because Egypt was like, everybody, the European came to Egypt and stayed, and then we have a lot of European mutations there as well. So training and education is very crucial, and evaluate. So first, we need to evaluate the knowledge. What do they have? What do they know about CF? Then you create a program for teaching. Developing national training program is very important, and teach people there, and then they go teach others. So train the trainer, if you will. And then engaging hospitals, and then very important to engage the Ministry of Health. And for me and my team in Egypt to get to the Ministry of Health, because there is a lot of bureaucracy there, we were able to find people, because it's over there is who you know. So one person, the head of the program in one of the universities, related to the Minister of Health. We send letters. We came from every direction. So now we have connection. So every time I go to Egypt, I send a message, can I meet with you? And I meet with them. So been very, very helpful. So the goals and of the collaboration. So we are collaborating. First, we collaborated with Turkey. That was my first global team to work with. And they're awesome, not because they're sitting here in this table, but they are amazing, and they are perfect image and perfect picture of train the trainer. So now they're going everywhere to train other people. So you need to increase the awareness of the CF, of the presence of CF for the physicians and the teams in there. Develop CF guidelines. So I had sabbatical 3 years ago, and I went in and I actually developed CF guidelines for them, using our guidelines and adjusting it to their resources. Training faculty, and I brought my team. A lot of my team came in, and were happy to come to Egypt with me, and also Turkey. And developing the CF registry, that is work in progress. Every university have their registry, and we need to combine it. So it's coming soon. And then connecting, they really lack nutritional and physical therapy expertise. So I always bring in our physical therapist and our dietitian with us all the time, and they are very well received there. The registry is not really need to be talked about. It's very important. When somebody asks me how many CF patients in Egypt, I'm giving them an estimate from each university. But really having a registry is really important. There are lots of registries that they can connect with. South Africa offered, the European CF registry offered. So we're working on it. It's a work in progress. I presented, and my team presented, the multidisciplinary approach, which is a not known thing in Egypt. And we talked to them in one of the universities I'm working with very closely. And, we just presented it. And a lot of the time you present something and you have no idea if they are buying it or not, if they're going to listen to you or not. So I presented the multidisciplinary approach, and we talked about it during the visit. And then the year after, they came to me and they said, oh, we've been doing it. And here is a paper that we're publishing about this. And I'm like, okay, I didn't even know that you're working on it. So it's been very exciting to just work with people, talk to them. We talked about infection control with the Turkish team, and they thought that will never happen. The patients bought it. They liked it. So it's not a big problem. So access to medication is a big thing. We do have a company, Abbott in Egypt, does the CREON, or pancreatic enzyme replacement therapy. And now there is a problem with supply, so it's really much reduced there. They don't have it, so we're trying. There is a company that came in and heard talking about CF, and they were able to do CF vitamins, which is really cheaper, more accessible to patients in Egypt. And then again, as we go every year, and I've been talking to the Egyptians since like 2007 and even a little before, and drug companies got interested. So there are 2 drug companies that came and said, we are doing TOBI, or tobramycin solution for inhalation. So we have 2 now that just launched in Egypt, and very reasonable price, and the companies are excellent, the pharmacy. And then now we have a problem with, we have the equipment from MICFA, but it's been a while, and we don't have supplies or some people to help with any technical issues. So now Elitech is coming to Egypt, and they are very pushy, very much so. They're there, and we're going to be able to get the sweat testing. OTSAT is a Turkish company that gave us the equipment before, and they actually are going to be there as well to surface their equipment. So improving access to medication, again, through lobbying. We talked with the Ministry of Health. We have now people from the universities, working with the Ministry of Health to see what's needed to teach the physician there, because they go there to get their medication, and if you don't know what CF is, you're not going to treat correctly. So lobbying is very, very important. We have also an advisory board that's helping us. This is the guy in the middle is the assistant to the Minister of Health, and he's the one connected to the rare diseases. So he's the one that we work with all the time. So because of lobbying, we were able to facilitate teaching the Ministry of Health physicians, but also medications come in. They had one of our physicians in Egypt joining as a consultant, and they've been really doing very well. This is a summary of the ETI. So because of the lobbying and because of constantly talking to Vertex about the importance of having Trikafta or ETI in Egypt, it was, finally they came to me 2 years ago and they said, we're going to be able to give it to you in Egypt as a donation program. At the time, I didn't even know that there was a donation program, but and now it's in Egypt, we have it, and it's huge difference, making a huge difference in patients' life. We have 150 patients on it, and it's 6 years and above, so we're trying to get it for the younger one as well. This is a patient on oxygen, that had the oxygen mask on, that came to me about a year ago, and he said, I'm the oldest CF patients in Egypt at 25. And he started Trikafta. He was on 4 liters of oxygen. He's now in room air. He's working. He's enjoying himself. He's in the sun. So this is a very good success story for him. CF National Advisory Board is formed, and QI work. We have been doing QI teaching there, and again, I've been teaching it a lot to this specific university, Ain Shams University, and recently, like a few months ago, they came to me and they said, "Oh, we did a QI work, and here is our results, and we're writing it up." And again, I wasn't aware, so I was very excited to see it and review it for them. The BMI and the FEV1 changing from this quality improvement project was amazing, what they did with that. And this is just a summary to tell you what the process is that we need to do to be able to, go to end up with quality improvement for this team. And with that, I am going to stop. The goal is to have the median survival in these countries as good as here. In Egypt, it's about 8 years of age. So we need to increase that. And with that, I will end, and thank you very much. And then I don't know, questions later? The questions will be at the end, I guess.
Thank you, Dr. Nasser. All right. Our next speaker is Mary Helmers. She earned her Bachelor's of Science degree from the University of San Francisco in '83. Following graduation, she began her nursing career at the Veterans Hospital in San Francisco. And in '85, she began specializing in pediatrics, working in various areas of Stanford Children's Hospital as a staff nurse. In particular, Mary's area of interest was pulmonary medicine. She began taking care of patients with cystic fibrosis, working on the inpatient unit where they cared for children and adults with CF. Before starting a family in '92, Mary worked in the outpatient clinics in the allergy, immunology, and CF nurse coordinator. And over the next years, Mary's role included relief nurse coordinator for the CF clinic and adult CF nurse coordinator, June 2000 to 2008. And then in 2008, she transferred to the role as the pediatric CF coordinator until she retired from her position in November of 2023. Now Mary stepped into the role as a relief nurse coordinator for the special projects in the CF Center, and this allows Mary to continue her work with the international training programs. Mary.
Thank you. So I'm going to talk on the experience and benefits of Train the Trainer. I'm going to talk a little bit of how we started our training with the IMTI group, and then I will take you on a little journey of our travels to Peru. Dr. Carlos Mila is our center director at Stanford Children's Hospital, and he is from Peru. And so he guided us on our way to Peru to help those in the hospitals there to help and collaborate and try to forward some type of cohesive group for CF patients and families there. I have no disclosures I have no relationships to disclose. So enhancing pediatric cystic fibrosis care in Peru, it's a collaborative initiative. The collaborative initiative was led by the CFTN, the CF Training Network, through the International Mentoring Training Initiative. Stanford's group, our group of nurses, doctors, pharmacists, nurse practitioners, social worker, administrative assistant, RT, and dietitian were trained by them and helped us to utilize high-performing mentor teams in the U.S. to help them bridge over for us to go to Peru and help train them. The project was funded by a grant from the Cystic Fibrosis Foundation, and all resources were covered. CF care in low middle-income countries face challenges due to fewer resources and less specialized care. And in Peru, I can tell you, it was very scarce and the resources were very limited. In preparing for our collaboration with our Peru colleagues, we completed an IMTI training. To ensure success of our mission, we had to do a 5P gap analysis was conducted to identify needs and challenges that were going to be amongst us in Peru. A 5P gap analysis, when you look at an organization like a hospital or hospitals and see that what challenges and things need to be added. So we did all of this prior to going to Peru and before Peru colleagues came to us. Our goals were in close alignment with the CF Foundation's mission, which was to choose best practices and care protocols established by the CFF. Our goals and outcomes. Following the analysis of the center, deficiencies were identified. We wanted to improve quality of CF care in Peru. We wanted to enhance clinical outcomes. CF centers in Peru were well organized and functioned as a team. This was our outcome. They weren't perfect, but they were better than they were. And we wanted them to go from multidisciplinary to interdisciplinary. Multidisciplinary meaning there were people working in CF, but they were fragmented. We were trying to pull them together as a team. 2 visits were scheduled and completed, allowing for hands-on training. We continue to look at their systems and make improvements. We still do that today. The project was well received, and ultimately, the quality of CF care in Peru will be improved. It will not be overnight. It's very much baby steps, but we have made some changes. The IMTI, the International Mentor Training Initiative, the Stanford CF team, we received our training certificate 2 years ago at Arizona at NACFC. After our training, we were ready to host our Peru colleagues. They came to us in March of 2024 and were with us for a week, and they were our special guests to share our experiences with people, to care for the people of CF. Then we embarked on our journey to Lima, Peru in August of 2024. We see our visits as the continuation of a long-term relationship between our centers, and we hope to learn as much from the Peru CF team as they do from us. Again, our experience was to establish a long-time partnership between the two centers and colleagues. Our goal of improving quality of care, clinical outcomes, and life expectancy for individuals in CF, with CF in Peru. Enhance their traditional CF team like we have here in the U.S. by providing comprehensive training and mentoring to our Peruvian colleagues. Again, that's still a work in progress. To refine and implement standardized guidelines for CF diagnosis and care in Peru, align with the best practices and care protocols established by the CFF. In Peru, there is no registry. Even the team that focuses on CF doesn't keep a database. That is something that we have been trying to encourage. I know I have been trying to encourage it with the nurse. However, because of all the political stuff in a hospital, nurses and people get moved without their knowledge, and so the nurse that was working with me got moved to another floor. So it's really hard to try to get the cohesiveness because things move quite rapidly. I put this picture up here just so you could see Peru. The star, the orange star that you see, that's Lima, and you can see it's on the coastline. So further in my talk, you will hear about a lot of the patients and families don't have access to care because they live up in the highlands. So it's hard for them to come down or get resources. The incidence of CF in Peru is about 1 in 8,000 individuals, and that's based on the incidence in Latin America countries. CF newborn screening was enacted into law, but it wasn't performed routinely. That has since changed. It's gotten better. No sweat testing was available in the public system. Many people with CF die in their teen years. Very few live to adulthood. Teens meaning they consider an adult 14 years of age. And so when you're 13, you get transitioned to the adult center. Care and resources are centered in Lima, making travel difficult for those who are located in the provinces or highlands, like you saw on the map. There are 2 pediatric CF clinics in Peru. The El Niños Hospital, which is a government-funded hospital that provides care irrespective of what you can pay. Very, very limited resources. And Hospital Nacional Rebagliati, which is available to the people who have salaries and are employed, and that's about 50% of the workforce. So we started our trip. Now I'm going to take you on our little journey to Peru and what we've accomplished there. We left on Saturday night very late and arrived there very late. Interestingly enough, Peru's a long, not too quick of a flight, but it's only 2-hour time difference. So that was easy to get used to. Day one, we started off with sightseeing and team building. Obviously, Dr. Mila being from Peru, and he knew the great places to go, we wanted to immerse ourselves in the Peruvian culture. So that Sunday, we really took the day to walk around, look at areas, and then enjoy lunch. This was our team that went. Dr. Mila, our center director, Jackie Spano, our nurse practitioner, and newborn screening, and also for research. Me, Jack Kelly, we had an interpreter. Biggest benefit that we could have ever had. Although Dr. Mila and then Laura Banuelos, our patient service coordinator, spoke Spanish, we were able to fund Jack to come. And Jack was with us when the Peru colleagues came to us at Stanford, and he went with us. That was a huge help. Debbie Manette was our social worker, Jessica King, RT, and Julie Mattel, our dietitian. So on day 2, which was Monday, our work week began, and it was a very busy week. Our first visit was to the Hospital Rebagliati, and that's where more private pay, you would say, patients go. These are people who are employed and have salaries and are able to go to this hospital. There's about 60 pediatric beds and 1,100 adult beds. It was very huge and very overwhelming, but very eye-opening. We started our discussions with healthcare team. Jackie started us off with talking about diagnostics and newborn screening. Then we went to the rehab center and Jessica RT gave a talk on the basics of management care of cystic fibrosis. In all these talks, we had residents, physicians, sometimes nurses, sometimes dietitians, social workers would attend. In the afternoon, they took us on a tour of the Ronald McDonald House, where patients who do live up in the Highlands in those provinces can stay. It was very well run. It was very nice, and they seemed to have everything well organized. On day 3, which was Tuesday, we were going to focus on pediatric clinical visit observations, social work discussion, and then we were going to go tour FICI Peru, which is the nonprofit organization that's put together by families of CF, and they help patients who don't have money to fund for things, and I'll go into that a little bit. So we were able to observe a clinic visit. So this clinic visit, after our Peru colleagues came to see us, we're able to get this little bit together. So the clinic visit we observed was the MD, the dietitian, and respiratory therapist. They visited with a pediatric CF patient. Normally, before we met with them in March, usually it was just the physician. The physician would do spirometry, everything about the visit. There was no multidisciplinary team there, and definitely no nurse. The nurse was never involved, which was interesting. But when we saw the clinic visit, their dietitian, Mariana, and Cecilia, the RT, were working with Dario to see this patient. They helped to coordinate, and they were working as an interdisciplinary team at this visit. So that was one step that we had observed that happened from our visit with them when they came to see us. We then went on to the social work discussion. Debbie, our social worker, did a formal presentation followed by a discussion amongst all the participants. As you can see in this picture, there were a lot of social workers, and Dora in the picture with Debbie, our social worker, she was the top-notch social worker who unfortunately at the end of our visit told us she was leaving. She had power and she had persuasion, and sadly she had to leave, but she got moved up to a higher thing working with government. But all these social workers looks like a lot, but you saw how many patients were in that hospital. These are all the social workers for that many patients. So to even have somebody interested in CF was pretty amazing. In the afternoon, we went to FICI Peru, which is a nonprofit organization that supports patients with CF and their families. They're very well organized, and it's a family run. They work to increase awareness and fundraise to support their program. It acts as a care provider to fill in the gaps in the healthcare system. Like I said, for those patients that live in the Highlands or even those that live in Lima that don't have the resources or help to do CPT on their child, they will come there and get treatment. Not every day. It could be once a week. It could be once a month. It could be once every 3 months. And that's considered getting treatment. That's how low the resources are. Has an RT, a nutritionist, and a psychosocial support for their patients that come. Families travels to the gym location to receive these services as well for laboratory testing and to get medical supplies like nebulizers, compressors, things they may need at home. But with that said, here's the little room. It's not that big of a place, and really, you only can have one patient at a time because of infection control. So it's servicing patients, but not able to service a lot of patients at one time. On Wednesday, Dr. Mila started off with pulmonary complications discussion, and then we had a nutrition and GI discussion. Excuse me. Dr. Mila reviewed CF lung disease and outcomes. This was very well attended by residents, physicians, fellows, some nurses, dietitians, and RTs. Julie then went on to do a discussion on nutrition and GI talk, again attended by GI docs and dietitians. All our talks, and you can see in the picture on the top, that's Jack, our interpreter. He interpreted all our PowerPoint presentations in Spanish. And this discussion was to go over things that we are doing here in the United States on nutrition and care, and how we can maybe help guide them to help put some of these things in place in Peru. The nutrition resources are very limited. There's no growth charts. In fact, in the hospital, there's no EMR, formal EMR. Only physicians have access to a computer. So the RD has to go online for plotting patients, but there's no way for her to keep them. So every time she comes in, she can't show like a trend, like here you were last year or 5 years ago. There's no way to do that, unfortunately. In that afternoon, we decided to take a little break. When our Peru colleagues came to the Bay Area, we took them on a tour to San Francisco, and they immersed us and took us on a tour of the city center. Thursday, August 15th, we talked on medication management, nutritional management of malnourished adult patient, focused on nursing care, and visit to the adult center. Jake, our pharmacist, did a talk on pharmacotherapy. He did also a modulator talk. That'll be at the end of the presentation, but he went over all the medications and stuff that we have here. And at first it felt like we were telling them everything we had, but they wanted to hear what we had, and they wanted to know what options were out there, because they're striving to get that. Even as though it may be difficult, it's something they still wanted to know. I did a talk focused on nursing care. Interestingly enough, prior to me going to Peru, I had to get approval. The picture with myself, the middle person is Violeta Estrada. She is the CNO in Peru, and Juana was the nurse that I was working with. I had to write a letter and get approval to meet with her, which I did. And then I did a teaching session with the nurses in Peru prior to going, because when we were there, our time was limited. Interestingly enough, there's no nurse coordinator in Peru. There's nurses, but very few that do CF, and those that do, it's very limited in what they can do. When I went to meet with her, Dr. Mila, myself, Juana, and Jack, our interpreter, came. And Dr. Mila didn't say anything at first. He let me go on the role of talking to Miss Violeta Estrada, and with our interpreter, she could tell my position here, and she understood my position, but the cultural differences are so big that she was trying to explain to me that it would be very hard for a nurse to be able to do all this stuff there in Peru. So we both understood each other, but since then we've had numerous conversations via email, and we're trying to still get nursing involved, and she's been very helpful in trying to get her nurses somehow involved in some small way. So I felt that was a very big plus. In the afternoon, we went to the adult hospital. So this is the public hospital for adults. And we went there just to tour it. As you can see, it's very old. In fact, in the middle picture, if you were to look in that room, there's metal beds, just one right after another, about 30 of them. Oops, sorry. And no isolation policies, but it was like looking back in time. I have to say a lot of this, these older hospitals that we viewed, the adult and children's hospital, it was eye-opening. You don't realize what we have here and how little they have there. But they are still working to try to care for their CF patients. It's administered by the Ministry of Health. We spent time with the team in Peru discussing specific cases. One case in particular of a 20-year-old girl who was a patient here. Remember I said they transitioned at 14, so she's still quite young. And her family was in the audience, and it was very sad. It was actually heartbreaking because she was so sick. And this family sold everything they had, and because they were in the highlands, and moved down to Lima to be with their daughter, who sadly 2 weeks after we came back, she had passed away. On day 6, on the Friday, we visited the National Children's Hospital, and then we had a discussion regarding experience and management of modulator therapies. And then Edith, the nurse, hosted us a dinner. The Children's Hospital was a little more newer than the adult hospital, public hospital, but still, the care was, the unit that we went in and visited was very, like, back in the days, even way back in the days. And patients there was 2 CF patients. They weren't there's no isolation. One was, they were sick, they were a little more than 6 feet apart, but they were in the same room. All the kids were in the same room. We met with hospital administrators to discuss our roles within CF Center and challenges facing Peru's healthcare systems. The goal of this was hopefully to have these administrators hear what we felt was needed and what the Peru colleagues wanted to happen in their hospital. But the eye-opener of seeing those kids in the hospital, there was a 5-year-old and a 10-year-old, and they looked like a 3-year-old and a 6-year-old. It was like when I first started in CF in 1985, and probably they looked even worse. And it was just an eye-opening experience, not realizing that this still exists in other countries. Jake did a talk on modulator era discussion. They were very interested in our experience with modulators. At this time when we went, they did not have access to modulators. They do have patients, though, that are modulator eligible. In the evening, we had a nice dinner and karaoke at Edith's house. Again, a time to experience homemade Peruvian meal, get together, talk about what we've accomplished over the last week, what we want to continue to accomplish, and just getting to know each other and bonding. Both have very valuable information. They gave us information and insight, and we gave it to them. Lastly, on day 7 was Education Day with FICI Peru. They put on an Ed Day, and all of us spoke, and this was for families and physicians and nurses and healthcare practitioners. Final thoughts, our host team was amazing in their passion and graciousness. The healthcare system has very limited resources for basic CF care, such as meds, nutrition, nursing. Healthcare team is dedicated to changing the direction of where they're going. And FICI Peru is an amazing resource for patients. Our plan going forward is to maintain collaboration with the team in Peru to continue to work on our goals. We had a last team dinner, and then we left. And in January, Trikafta did arrive in Lima, Peru. And I just want to say thank you to the CFF for their gracious grant for us to be able to do this. The Milagani Family Foundation, who gives to and helps people with CF and other things in Lima, and to my Stanford Pediatric team for all their work that they did on this as well. Thank you.
Okay, so my name is Kathy Mims, and I'm from the UAB Children's Pediatric CF Center. I help to coordinate the International CF Training Network and the MD program along with my other colleagues. So I'm happy to introduce now Martin Sestari. He's a licensed physiotherapist specializing in pediatric respiratory medicine. He's been the coordinator at the CF Center in Nodi Hospital in Mendoza since 2020. He participates alongside the rest of the core team in the International CF Training Network program and is working to improve the quality of care in his country and in Latin America. Martin has become an expert in and user of the REDCap registry that we have developed through UAB, and now trains and onboards new teams on the platform, and he coaches teams to use that data for improvement work. So I'm happy to welcome Martin, my friend and colleague. And
hi, everyone. Thank you, Kathy, especially for the invitation to participate in this session. So I have no conflict of interest. I must only comment that our team participate in this grant. So I covered the following points. First, I talk about we manage data before REDCap. Then I describe the implementation of the system and how we access and use the data. And finally, I describe the benefits for our team. So before RedCap, our processes was quite chaotic. So we use only an Excel spreadsheet we kept all the data. So it was very difficult for us write reports or map trends or make graph. So once University of Alabama teams invite us to use RedCap, we consult with our ethics committee to get approval. After 2 months, we receive authorization to begin. Then we complete a 2-week training period and collect the consent forms. We also design and refine a new form for the patients. And this form allows us to record patients' data during clinical visits and hospitalization and when the patient is in diagnosis. And finally, we divided the task of filling out the forms. For example, the clinical visits are filled out by our dietitian. As you can see, we use only 3 different forms. One-time forms, which in orange, which we fill out when the patient is diagnosed. In red, early forms, which we complete after the year ends, like annual review forms and therapy annual summary forms. And finally, event forms, which fill out after each clinical visit or admission. So this is our dashboard, where you can see how we keep track all of our different forms. Data collection is a powerful tool for management the data. We use it, for example, for clinical visit, for pre-visit preparing, post-visit, clinical history summary, or evaluation individual trends. And for example, we can get an overview of the patient status, which allow us to tailor the consultation to the patient need and progress. For example, you can see the diagnosis data or the most recent clinical visit data or different trends like lung function status or nutritional status. And we also use the data to improve our quality of care. Sorry. I need water, please. No, water here. Thank you. Cheers. Thank you. Okay. So outside RedCap, we create a local form to our hospital to gather feedback from families. This helped us understand what they think and record clinical visit times. We also create a process map to streamline our workflow. And we printed medical order and charts that replaced the old paper forms doctor brought by hands. So all these changes allow us to reduce clinical visit time from 4 hours to 2.5 hours. So it was wonderful for us and for the patient, no? And finally, what are the benefits of the registry? When dealing with individual patients, it helps us understand the natural history of the disease and determine the clinical effectiveness of the treatment. For example, as you can see in this trend, the patient lung function was 75% at the start of ETI therapy. Lighting bold symbol means starting the treatment. After starting the treatment, his lung function increased to 100%. And over time, we notice his lung function decline, so we decide admit him. When you see red line, means admission. So during his hospital stay, his lung function recovered. And beyond individual patient, we can derive benefits for the whole CF population. For example, by tracking the number of hospitalization or the days of hospitalization or the use of antibiotics, we can more effectively manage our physical and human resources, ensuring we continue to improve the care we provide to our patients. And on the other hand, by using registries, we strengthen support network, compare our data with other centers, and share experiences. Thus, we can improve the quality of care and the life of our patient. So, in conclusion, REDCap is a user-friendly, quick to implement, and adaptable even in resource-limited set. Thank you.
Okay. Now I have the pleasure of introducing my colleague Stacy Self. Stacy is a licensed clinical social worker with over 25 years of specialized experience in cystic fibrosis care. Her expertise spans CF transition services, quality improvement coaching, newborn screening protocols, relationship-centered communication, and international CF team training. Currently, she serves as the clinical training manager for the International CF Training Network and assistant director of Dream a Little Dream, a UAB nonprofit spinoff dedicated to advancing the training and capacity of CF teams worldwide. Stacy has presented her work at national and international conferences. Stacy, welcome.
I'll bring my water. Okay, I feel like you probably can't see my face. Thank you guys for inviting me to participate in this great panel of speakers. I'm going to be talking about the International CF Training Network outcomes. And we are graciously funded by the CF Foundation to do the work that we do. So I want to ask you guys to think about outcomes, not just clinical outcomes, but think about what it takes for us to get to the point where we can improve clinical outcomes. And so just this idea of the power of early wins as we're, training teams that are maybe just starting to form as a team. So what we try to focus on is the fact that every team can celebrate small successes. Mary talked about sometimes it's like stepping back in time. It may be starting a pre-visit planning meeting. It may be decreasing your cycle time in clinic. But we can celebrate these small successes, and then that fuels the momentum to keep going for, the long-term goals that we want to reach. So we try to encourage teams to focus on what's in their sphere of control. We say a lot of times, what's the low-hanging fruit? A lot of times teams will think, oh, we've got to, reach out to the Ministry of Health. We've got to, talk to the hospital administration. And you may need to do those things, but right now, what's in your sphere of control that you can change? So that success builds and helps them to be able to have the confidence to tackle bigger challenges. And so I just wanted to stress that this journey is important for the final destination, which of course is improving clinical outcomes in low and middle income countries. So this is kind of a busy slide, but I wanted to give you a little bit of, you've heard several people mention the International CF Training Network, and I wanted to just give a little bit of a background on what that is in case people here aren't familiar with it. So just to zoom in for a second, back in 2014, Hector Gutierrez led our team to kind of start this journey. And it was his vision with Dr. Lena Boza, who's here with us today, that really started this work, this important work. So we started with one small center in Santiago, Chile. I think they had just in the low teens number of patients. But over the years, it has really grown from that vision. So jumping kind of a couple of years later to 2019, our team had formed partnerships with 3 teams in Argentina. And it was a busy year, as you can see. There were a lot of benchmarking visits, teams coming to visit us at UAB, our team going to visit teams in Argentina. And then fast forward to today. Over the last year, we have trained our first private center in Santiago. We continue to build partnerships in Argentina with new centers, talking to an adult CF center now. We've recently had some conversations with adult CF center in Cordoba, Argentina. Last year, we planned a symposium where there were 21 teams from all over Latin America that came together to learn about quality improvement and guideline-based care. So also just to give you a little bit of background about our Train the Trainer program, it's kind of based on 5 phases. So the first phase is just identifying those teams. And I think it was Dr. Nasser that said, you want to have teams that are interested in working with you, that have the desire to change and to improve, that kind of have the vision for, we're here, but we want to be somewhere else, and let's take the steps to get there. Phase 2, which I really think is kind of the heart and soul of our training program, is the benchmarking visits, the bi-directional benchmarking visits. So this is a time where the trainee teams come to visit our center for a week, and then we go about 6 months later to visit them in their center. It is a very intense week. The people that have experienced it in this room can attest to that. But we focus on teaching guideline-based care, teaching quality improvement methodology, observing clinic, observing, the different processes in the clinic. But the most important thing, I think, is the relationships that we build. Like, that's the time when we get to really get to know the team members that we are working with. They get to know us, and it just lays a good foundation for, the future of our work. The next phase is just ongoing assessment. We have monthly webinars that we provide for teams. We're assessing how they're doing, how are they developing, what are they getting stuck at, on. It's hard. You get busy, you lose momentum. We try to provide encouragement with that to help them to keep moving forward. And then you've heard mentioned the MT, International Mentor Training Initiative, which is a program that we developed to teach teams how to train other teams. So once a team has gone through the training, they're at a point where they're high functioning, they've improved their outcomes, they've improved their processes, and they're now ready to train other teams. And so they go through that program before they begin that process. And then phase 5 is just ongoing collaboration and peer training. So what are we seeing from all of this work? What's the fruit of what we've done? So the process improvements for all UAB trained teams in Latin America, these are the common things that they've improved. So all the teams now have multidisciplinary care, or I liked Mary's word, interdisciplinary care. So they're working together as teams. They're having pre-visit planning meetings. They're spending time preparing to see patients and families. They're using quality metrics. So, and all the teams that we work with are now using our REDCap registry. So we're really building that database where teams can not only see at the point of care how patients are doing, but also from a center perspective. And then hopefully we will be able to compare centers eventually. Process documentation as well as process standardization. So teams are looking at their processes, they're learning about how they do the work, where can they improve, and once they get it to a place where it's working, they standardize that process. guideline-based care, family empowerment. So not only at the point of the clinic visit of empowering families with information about their health through using, the data that they have in REDCap, but also partnering with family organizations, or even like there's a team, MEDS in Santiago, Chile, is starting a family organization, a new family organization. So this is critical to this work, and we're encouraging teams to continue to, utilize family expertise to advocate for what they need. And then managing up and out. All of the teams have increased, team time in clinic, managed up for additional resources. So, those are all the things that the teams have improved. So what about clinical outcomes? We've seen a lot of really amazing improvements. Improvement in lung function, a decrease in Pseudomonas infection rates, and a decrease in pulmonary exacerbations. And then we thought, well, what about, is it just modulators? Because our teams in Argentina have had access to modulators, for a while. And we thought, do we just need to put modulators in the water and everybody with CF will be better? But, we know that there's some people that don't have access. So you can see that even in the patients that don't have modulators, there's been a really big improvement in FEV1. So we were really encouraged to see that. And if we didn't have that data in the registry, we wouldn't be able to understand that. So in terms of clinical outcomes, we've seen an 11% increase in FEV1, 30% increase in BMI, and a decrease in hospitalizations of 70%. So, we're learning that this is sustainable. Teams are improving. We have 8 teams in Latin America that have transformed into high-functioning CF care centers, and now 4 of those teams are now training 6 additional teams in their regions. So this is it's a growing network, and we're really excited. We are partnering with some of our teams to take trainers from Latin America to help us to train new teams. So it's really been exciting to see. So now I want to shift gears a little bit and just highlight some of the other work that's going on with some of our colleagues across the country. And I want to thank Dr. Heather Mustin and Dr. John Stevens for sharing some of their outcomes. They are from Indiana University, and they have partnered with countries in Central America for a couple of years, specifically Honduras and El Salvador. And you can see the CF clinic in Honduras was established in 2018. They now have dedicated clinic space. They have a spirometry. They're doing a lot with educating families and enzyme and best provision. The ongoing advocacy efforts have proved fruitful, and now they have access to Trikafta as of August 2025, which is really encouraging. El Salvador, they've had a program for a little bit longer, since the early 2000s. But Dr. Mustin and Dr. Stevens are doing grand rounds there. They are expanding their partnership to another team in San Miguel this year, and their first patient was started on Trikafta in 2024. They still, have a lot of challenges. There's limited provider knowledge and resources. Of course, access to medication is an ongoing problem, also affordability of the medications, and then just a lot of bureaucratic barriers. So their priorities moving forward is medical and therapy management. Of course, Trikafta, if you're going to start Trikafta, you have to have the infrastructure in place to monitor that drug. And so they want to make sure that teams are equipped for that. Routine clinic visits and early recognition by providers. And also they've mentioned, recognition of CF by pediatricians. That's kind of lacking there. So education and collaboration with CF teams, and they are also looking at, and realizing the importance of a data registry and have partnered with us a little bit to maybe try to test the REDCap registry there. So moving on to highlight some other work, and Dr. Nasser highlighted her wonderful work in Egypt earlier, but I wanted to thank Christine Noak from the Middle Eastern CF Foundation for letting us highlight some of the other work in this region. And of course, Dr. Nasser has years of experience and trained the team in Turkey, and now they are training other teams in the region. So that train the trainer methodology is really spreading. Also, the group from Harvard that went through our MT program, they have partnered with a team in Jordan, working on, multidisciplinary care clinics, guideline-based care, quality improvement, all of the things that we've all discussed. And now under the leadership of Bülent Karadig, who I see out there, Turkey is partnering with Tunisia to do this training. So it's very encouraging what's going on in that part of the world. Some common achievements among all of this work. There's been center development and networks, diagnostics, which is, of course, key, multidisciplinary team care, improved knowledge and awareness, and then, quality improvement, clinical and process improvements. So this is, shaping up to be a sustainable approach for this region. One more that I want to highlight, which you already heard about from Mary a little bit, but just wanted to share some of the outcomes from their efforts in Peru. They've established a multidisciplinary team and an adult program, implemented weekly team meetings, so working together as a team. They adapted and adopted the Stanford protocol, so, providing evidence-based care. They're enhancing family engagement, the increase in social work support and mental health focus, and then strengthened preventative care and education initiatives. And this is an ongoing effort. Mary talked about the webinars that she does with the nursing staff. Their team from Peru actually came to the symposium that we did back in October of 2024, and they were very engaged and excited about the work that they're doing. There was a newborn screening workshop. They do a lot of educational webinars on triple therapy. Neonatal screening is now consistently implemented. And Mary does bi-monthly Zoom meetings with the nurse. And they have CF funding sweat chloride testing now. So a lot of encouraging things going on in Peru. And I just want to highlight that Mary, really did a great job of showing you what the benchmarking visit looks like. It's an intense week, but it's a fun week, and we get a lot done in really a short amount of time. So this is shaping up to be a really big network of US-based trainers that are, passionate about helping other people in other parts of the country to improve CF for all people with CF. I wanted to highlight two more that have gone through the MT training here and are focusing and training on other teams. First, Columbia University, under the leadership of Hussein Siddiqui, has trained a team in Ecuador, and they've also been to other parts of the world. And then Grace Paul and her team are now going through MT training, and actually a team from India is also participating. So the hope is that they can train other teams in their region. So this has been, it's a growing network. We have a monthly meeting for mentors specifically so that we can learn from each other. How's it going? How did the benchmark visit go? Are we evaluating this work like we need to so that we can learn and improve the work? So I have to put a plug in for Plenary 3. My boss and dear friend will be giving the plenary session on the Train the Trainer program. So if this kind of sparked an interest in you, if this is, you're like, man, I would love to be involved in this somehow, I would highly encourage you to go to this, because he's going to delve a little bit deeper into our work, and you'll learn a lot more about the program. So thank you.
Okay, now for our final presenter, I'm very excited to introduce Noor Elshar. Noor is a Syrian-American humanitarian and global health advocate whose lived experience as a post-double lung transplant recipient deeply informs her work advancing equity, compassion, and inclusion in cystic fibrosis care worldwide. Guided by both personal resilience and professional dedication, she strives to bridge gaps in access, amplify patient voices, and inspire a more human-centered approach to healthcare. Noor, we welcome you. And Noor participated with her team in the MT program, so she has lived through that too, and hopefully will share a little bit. Thank you, Noor.
Good morning, everyone. Thank you all for joining us here bright and early this morning. And I just want to share that I will be speaking about something I'm very passionate about, and it'll be Beyond Borders Through My Lens, the global reality of cystic fibrosis and the call for collaboration. When was the last time you stopped to think about your breath? That simple, rhythmic act that keeps us alive. It's something we so easily take for granted and don't even think about. Now, imagine being told that your breath, something so instinctive, would always come with effort. With treatments, with schedules and medications, with constant ticking of the clock. And imagine that where you live in the world determines how much breath you get to keep, literally. My name is Noor Elshar, and I was diagnosed at 5 months with cystic fibrosis, a disease that knows no borders. Yet, where you are born often determines whether you will survive. This year, I was blessed with the opportunity to travel with my QI International team to both Turkey and Jordan, and then with my family to Syria after 15 years of not being there. These 3 countries forever changed how I see the global landscape of CF and what it truly means to live this disease outside the United States. I would like to acknowledge my sincere gratitude to the MT team for teaching me and our team and everyone else who's a part of their learning experience about quality improvement in low and middle income countries or just outside of the United States. And a special thank you to our QI team from Boston as a whole, and a truly heartfelt thank you to our leader, Dr. Amit Euler. Thank you for believing in me, Dr. Euler, and trusting me to take on these beautiful, rewarding experiences. So now let me tell you about where I went. We'll walk this road together. In Turkey, I met a determined and hardworking disciplinary team, a team that has been slowly building itself over the last several years. You could feel the unity in their work. Pulmonologists, dietitians, physical therapists, mental health professionals, and more, all collaborating to give their patients the best care possible. Their dedication was inspiring, their collaboration genuine, their growth visible. Each team member carried an unspoken pride, the pride of doing the best they can with the tools they have. And yet, even in Turkey, where systems are far more established than in neighboring countries, access to new medications and modulators remain limited. I remember speaking with a patient partner who shared a heartbreaking story or a heartbreaking reality. Each time her daughter needed access to her expensive modulator therapies, she had to go to court. Again, she had to go to court. A judge would decide whether the medication would be dispensed for her daughter and covered by the country or not. Imagine that. Your child's next dose was not necessarily decided by medical officials, but by legal procedure and legal authority. Their clinicians are capable, compassionate, and committed, but they are still working within a system that lacks the resources and technologies. We often take for granted all of these things in the United States. Now, let's venture off to Jordan, a country close to my heart, and one that left me both humbled and heartbroken. For over 2 years, I've worked with teams in Jordan as a patient partner and as a voice resonating with those living with cystic fibrosis who, like me, fight for every breath. During my visit, I joined a family day that our team had organized for parents of children living with cystic fibrosis. I shared the work I'm most passionate about, the Mental Health Project, alongside our psychologist from Boston Children's Hospital, Dr. Snell, and our other psychologist from the Syrian American Medical Society, Rueda, who the Syrian American Medical Society has 2 mental health centers that are established and up and running. So they were very willingly happy to help these patients. That moment, seeing local and international teams collaborating across borders, this was the embodiment of what I believe in collaboration in its purest form. The emotion in that room was unlike anything I've ever experienced. Mothers and fathers held on to hope the way one clings to oxygen. Desperate, grateful, determined. They looked to us for guidance, for access, for reassurance that their children mattered just as much as anyone else's. What struck me the most was their creativity and resilience. With minimal resources, they were doing everything that they could to help their children survive. Parents were making aero chamber spacers for their child's inhaler out of plastic water bottles. Again, out of plastic water bottles. Cutting and reshaping them to mimic the devices they could not afford. One mother in Jordan, this is a story that really struck me, would walk every single day to a small clinic at a decent distance so her child could receive a nebulizer treatment because she could not afford having a nebulizer compressor at home. And pulmonologists in Jordan, let me tell you, they often see 50 patients a day. 50. Can you imagine? A disease that demands individualized care reduced to minutes per patient. Yet despite the odds, they persist. Innovating, adapting, refusing to give up. That kind of courage humbles you. It teaches you that love and determination are sometimes most powerful and the most powerful medicine of all. Now, let's venture off to Syria. And then came Syria, where my heart and soul will forever reside. A place that holds my roots and some of the hardest, that holds both of my roots and some of the hardest images that I've ever witnessed in person. The reality there was stark. Let's imagine again. Electricity in Syria only comes 4 times a day. Picture this, 4 times a day, 1 to 2 hours each time. Imagine needing oxygen or performing your airway clearance therapies. You can't just do it when you need to. You wait for the power to return. And then you race against time to finish before the lights go out again. This is a project in itself. I experienced that when I was there, and I had to adjust my own therapies depending on when the electricity came. There is no designated CF clinic in Syria. Again, no designated CF clinic. There is no CF specialist in Syria. Only one pulmonologist who was trained outside of Syria about CF and then returned home to take care of patients, and the 3 individuals that I know of who have cystic fibrosis. One of them is my second cousin. There were times I would find her sending me messages and it would be 2 o'clock in the morning her time. And I would ask her, what are you doing awake? She'd tell me the power just came, so I'm doing my best in a nebulizer treatment. And it was true, when I was there, one of the times was 2 a.m. The other 2 were children of a mother who often sends me video messages and always asking for help and advice. I guide her the best I can, but her access to medications and supplies is almost non-existent. Her daughter is unable to attend school because of her disease being more advanced and endless infections occurring when she's with her classmates. How can we collaborate? Again, how can we collaborate when so few are even diagnosed? When awareness itself is missing. That's why I always return to one simple message. We must plant the seed of awareness. Awareness is where everything begins. Without it, there's no foundation for care, for policy, or for progress. When we talk about international collaboration, it sounds simple. But let me tell you, it's not. We think it's just about sharing knowledge, send resources, bridging gaps, but in reality, it's far more complex. During my visit to Jordan, I had the chance to meet with the Ministry of Health to discuss the lack of access to the most essential, simple CF medications. Enzymes, inhaled antibiotics, vitamins, just to say the very least. We weren't asking for luxuries. We were asking for survival. One official said something to me that will never leave me, and I wish it was something positive, but I'm just sharing my reality. He shared that our patients don't live long enough to fund all of these therapies. So with the understanding, or the message he was trying to relay, is that it wasn't worth it. That statement broke me. Because how can they ever live long enough if they're denied the very treatments that could help them survive? I stood up with my face filled with tears, so emotional, and I said, we have to help save these children. Please. That moment crystallized a truth I'll never forget. Global advocacy is not only about funding, it's about belief. The belief that every child, no matter where they're born, deserves the same chance at life. Collaboration is what allows us to send experts across borders, to share their knowledge, skills, and expertise, to educate and empower local teams, to help them develop systems that work within their realities. True collaboration isn't about copying and pasting what works everywhere you go. It's about tailoring, teaching, and transforming, creating systems that honor both their local cultures and global standards of care. But collaboration also demands patience. Again, it demands patience. Progress does not happen overnight. Seeds take time to root. You have to nurture them with persistence and humility, allowing them to grow into trust, knowledge, and lasting change. You have to build trust with anyone you want to collaborate with. We may feel far removed from the families in Turkey, Jordan, Syria, or any other country globally. But there was a time when the United States was not so different. I want to also share that above all, global collaboration requires listening as much as teaching, respecting local voices, being willing to start small again and again and again. CF Care evolved here because of patients, parents, communities, and clinicians united because they shared data, raised awareness, and refused to stop pushing forward. If they could build that foundation, then we can help others do the same today, tomorrow, and in the nearest future. So where do we go from here? We begin with awareness. We foster education. We strengthen partnerships. And we ensure no CF patient, no matter where they live, remains invisible. Collaboration is not charity. It's equity. Again, it's equity. It's standing side by side and saying, your child deserves the same chances that I do. It was very difficult for me to stand in Jordan in front of all those patient families. And I looked like I did now, and I know I was a beacon of hope for them, but it was so hard for me because I want the same for their children. If each of us contributes just one seed through awareness, mentorship, training, or sharing resources, those seeds can grow into a forest of change. Every breath I take today is a gift. From science, from knowledge, from medicine, from advocacy, and from those who fought before me, they will never be forgotten. But that breath carries a responsibility. It carries a huge responsibility to fight for those who still wait for theirs. So I ask that we remember the mother in Jordan walking to the clinic each day, the families in Syria waiting for the electricity to return, the fathers turning water bottles into spacers for their inhalers, and the doctors in Turkey doing all they can with what they have. The ability to breathe should never depend on where you were born. I could say that all day, every day. Today I shared just a small glimpse of my personal perspective as a sentiment that there is so much we can do. Let us rise together for awareness, for access, for collaboration, and for the universal right to breathe. Because cystic fibrosis, again, has no borders, and neither should our care and compassion. I would like to share 2 verses that I live by from the Quran. Please allow me to share them with you, verses 5 and 6 from chapter 94. I'll say it in Arabic first. فَإِنَّ مَعَ الْعُسْرِ يُسْرًا وَإِنَّ مَعَ الْعُسْرِ يُسْرًا. صدق الله العظيم. These verses say, and verily, with every hardship comes ease. Again, with every hardship comes ease. Thank you so much.
Thank you so much, Noor. We really are appreciative of your heartfelt experience and sharing that with us, so thank you. Now we want to take a minute or a few minutes. We have about, 15, 20 minutes to take questions. We have a panel here. We are recording today, so we do ask that if you have a question, please go to one of the mics in the room. Thank you.
Awesome. All right. Thank you so much. Just a comment and then a question, but Noor, I mean, that was incredible, so heartfelt. I mean, you're a beacon of strength and you made it happen. You made all these adventures happen in your life, and you've been talking about it for 20 years, and I'm so glad that this year you've been able to find that that ability to travel and that voice. And it's getting stronger and stronger. Every time I hear you talk, I just hear this incredible strength. And I feel like we are all going to be on your shoulders and doing this work, because those words really lift us up. So thank you for this incredible talk. And I would say that I know that because of time, you didn't mention the other team. Like, we're all on the same level. I mean, and with Fadi and Leah and Carolyn and Chandra and Catherine and Eleni and Lena, I mean, this is the team that, you know, made it happen. And of course, Alda and Sama. But this work is really hard. And so I'm going to shift. So thank you again, Noor. And I'm sorry that I missed part of the other talks, because we had to go support one of our other fellows who was giving a talk. And maybe this is to Samia, to Hector, and others. You know, we work so hard to make some of these changes happen. And one of them, just specifically, I want to talk about is something that Noor just touched on, is medication access. I mean, it is one thing to work really hard and to make it happen, and then to keep losing it, to get it back and then losing it, getting it back, losing it. Now, Christine, who is, this tour de force in the Middle East CF Association, she will advocate for people directly going to companies and, making, doing those the contracting, rather than the Minister of Health. But I'm just wondering, what are ways that we're going to be able to, get a win and then be able to let, this happen and then go on to the next thing, rather than just keep going back and having to fight that same battle?
Thank you. Yeah, I mean, again, Noor, that's very touchy. I mean, I'm not going to sleep tonight. So, but yeah, I mean, my message is persistence. You just keep at it. Yes, now we don't have enzymes in Egypt. We have it. Abbott have been providing it for a long time, and all of a sudden they're missing some ingredients, and now they don't have it anymore. And they said by next year they'll have it. But what we do with the patients now? But again, persistence, working with whoever make the decisions, and I love the message of listening to the teams there, because I think I know everything, but I don't. So you have to really work with them, and you have to be open-minded enough to change direction. So it's a matter of keep trying. Like I said in my talk, you missed it. You heard that one? I mean, he's a good friend. So. But when I kept going there, and I've been going there, and the message that was said before is that persistence, and nothing will happen overnight. It takes years and years. I've been going to Egypt every year since '97. Then we came up with the study, and then every year. And then all of a sudden, I'm hearing about companies producing tobramycin solution for inhalation in Egypt. Not one company, but two. And I'm like, when did that happen? I didn't work for it. I just kept talking about it, and then they came along. So I think the message is persistence. It's not nagging, it's persistence. Just keep doing it and never give up, because you never know. When you teach about quality improvement, are they going to do it? Are they buying it? And then all of a sudden, yeah, they are. And so it's really persistence, my message.
Yeah, also I would like to thank Noor and all speakers, and also I would like to thank CF Foundation to have a session like that, because coming from the other part of the world, it's very inspiring us, and also what does North America CF meeting means for us. Just decreasing our burnout syndrome with my team, and because we are really still having problems every day. Our dietitian now sent to another hospital. I'm now struggling to get her back, although she was trained in Michigan and so on, but no one cares about that. Also, there is always a pressure from the administration of the hospital that, you are only seeing 10 patients in a room. You should see 50 patients like the other rooms. So this is happening in a university hospital. But also we have really thankful to CF Foundation, and especially Professor Samia Nasser for training us, giving the privilege of being trained by real experts. And then afterwards, now we are enjoying maybe the first mentee becoming a mentor for another country. And now we are facing the difficulties of how, which disadvantages can have and what are the obstacles, because we want to solve the problems in a very short period, but it's of course impossible. When we were in Tunisia, there was a boy, 8-month-old, and he had a respiratory insufficiency, and we advised him to be taken to the ICU. But what happened? ICU doctor refused to get him because anyway, he will die. I will give this chance to another boy. So I think one of the messages that also listening and also with the other messages, maybe increasing the hope of the doctors that their patients will survive. Even the patients don't think. I receive some messages from Iraq, Azerbaijan. My child has a chance to be an adult person. I say, okay, but with the education, no, okay, give it up. So this is happening in the other part of the world. So we are trying to help them. And unfortunately, the day after he was passed away, and he was the second child of an 28-year-old woman. And for Turkey, okay, it's good. We have the reimbursement of the drugs, and we have this special basic settings. But when we started, our survival rate, median survival expected rate was 41. Now we are happy that it's 46. And also, I think it's very important to also hear what's happening in the other parts of the world. And also, it's, I think, good chance to start with the training centers in US, but also we should go forward, and also we should, after training the centers, then we should motivate them to train the other centers inside the country and outside the country. And again, really, I'm very thankful on behalf of my team, thankful to have such a session. Thank you very much.
Hi, everyone. Fadi Asfour, I'm a pediatric pulmonologist in Salt Lake City, Utah. I'm from Jordan, and I'm really thankful that I was able to join the Boston team with Dr. Ahmed and Noor and everyone else. I think I just want to reflect on some lessons learned and then have an ask at the end. One thing that we did with the Boston team is there was 3 of us who are Jordanian physicians, American trained, who kind of tagged along with them, and I'm really thankful they kind of allowed us to do that. But it really was like an opportunity for us to give back to our countries. So we traveled with them, and we were part of the work. I think some of the things to keep in mind, like we know the American experience, we know the timeline of the foundation coming together, the centers, the medications, the registry, all that stuff happening. And what Noor said is like copying and pasting just did not work. Even we knew the order that made sense that happened. We had the 2020 hindsight. It just really we could not just copy paste and implement it there. And even like after a while of working, I think the importance of asking and listening and just going there, being in their shoes and understanding, we keep realizing it is back to the basics, but at a deeper level every time. Before we talk about modulators, we need to talk about infection prevention. Before we talk about maybe newborn screen, we need to talk about when you have one kid with CF, screen the siblings. When you have meconium ileus, screen the baby. So things like this that we take for granted is not even established. And I would say 2 years in, 2+ years in, we're still talking about infection control because they do not have the resources, they do not have the education. And Noor, small correction, they see 55 patients per half day, not for a full day, which is crazy. We see 5 to 6 in my clinic in Salt Lake, and sometimes I feel like, how did we even get through that? So, yeah, the issue is, I think, a combination of resources, education, but I think it takes time. We have been, I would say, 2.5 years right now, and what Ahmed mentioned is like, a Ministry of Health changes, everything changes. And I feel like sometimes it feels like we take one step forward, two steps backwards. So I might ask from the CF Foundation if it's possible, because the grants for MT are limited to 2 years. And I feel like 2 years is you're just getting started. You're just building the relationships. You're just understanding the healthcare system. And I really feel like now we're in a position to like do the deeper work, do the next level of work. And I would love for the Boston team to have the opportunity to continue for 2 more years. This work also needs funding. Everyone is donating their time for free, but people need resources to travel, to educate. So that's my request, and thank you very much.
Oh, that's only designed for tall people. Hi, I'm Dr. Naveen Hilali, a pediatric pulmonologist, Cairo University. First, Noor, your talk was heart-touching, and we felt every word. Thank you very much for being the sound for cystic fibrosis in low socioeconomic countries. Second, I would like to express how Dr. Samia made a hell of a change in our team in Egypt. And first, we see more than 50 a day, so just clearance also. It's just because the population of Egypt, of course, are way more. The facilities that we have, we learn to work with what you have. So making just aerospaces from water bottles is one thing. Even the kids now know how to do for themselves, not only waiting for the fathers to do. But maybe we started seeing CF patients since 2007, but working to establish a team and to go for teamwork started like maybe about 10 years ago. But we never lost hope. But the most thing we fight for is to make the Ministry of Health believe that these people are not just numbers who are going to die anyways, so don't waste your money on them. This is the hardest part that we have to deal with. Because if you see, literally, yes, the mean age of the Egyptians with CF is between 7 and 10, and that's the maximum age they reach. And as the doctor said, even when you have a place in the ICU, they don't give it to us, a patient with CF. He's dying anyway. So we need to put a pressure on hope and the right of the life, and that there should be perseverance and persistence and collaboration. Like Dr. Samia and her team, they all came to us this year. And we had a lovely workshop about quality improvement and how to establish a multidisciplinary team. We started working on that, but no, there were a lot of flashlights that we had to work more on that. The lack of the resources and the medications we still suffer for, but don't ever underestimate that we have to travel sometimes multi-times a year, and Dr. Samia has to come multi-times a year just to get the medications and to give it to these patients. We have to work with what we have to work, but we have to keep pushing on the power of persistence and the right of life to every patient with a CF. And first, to recognize that we do have CF. And thank you very much.
Do you have to? Oh, there we go. We had a question in the app I just wanted to get to. Somebody's wondering about how do you navigate modulator access when maybe the modulator is approved in the country, but the cost is prohibitive for the patient? And is there any way to kind of advocate for that, or what are the ways to getting the medication for the patient?
Yeah, I mean, for us in Egypt, it's donation program, so that's good. So I'm not worried about it. There is no restriction from Vertex on who to give it to or how to do it. They never asked me for record of the patient that started. So it's going well. And I think Vertex is adding more countries to their donation program. So lobbying is really important. And then from the Turkish experience, I mean, yeah, the drug is available, but it's limited and there's a lot of restriction. You just have to keep working with your country and with your, policymakers to change things, because otherwise it's not going to happen. So I don't know if anybody else have anything to add. So again, persistence.
Good morning, everyone. First, I want to say thank you to all of you on the panel. I was moved by each of you. I was a little bit late, so I'm sorry. The work that you do is it's beyond priceless. We can't put a price tag on it. So I wrote some of your names, and I'm not going to get all of you. So Dr. Nassar, Stacy, Martin, Noor. To find out, to hear what's happening in countries where there is literally zero or close to zero access is unbelievable. However, inequity exists across the board, even right here at home. So I am a mom of 2 boys who were late diagnosed with CF in 2014, and I was so overjoyed yesterday because I keep thinking about the first care team they ever had. And one of the staff members came up to me yesterday, and I could have melted into the floor because that moment gave me breath. They gave my sons breath. However, since they were diagnosed, one son is now 13 months without access to the care he needs right here in the United States. And my second son is now 2 months without the care he needs right here in the United States. When insurance denies us, when insurance works, but they claim, oh no, you're covered by someone else, but you're not covered and you were never covered by them, and they keep denying, what do parents do? What do the patients do? How do the patients breathe? How do they live? How do they function? How do they work? How do they find hope? So my question to you is, and thank you for allowing me the preamble, from each of your hearts and your personal experiences doing this valuable work here at home and in these other countries, what is the one critical thing that you would name that comes straight out of your heart and your head when asked, what do we need to do in our beautiful country of America that supposedly gives us more advantage? What do we need to do right here at home? What do we need to do for these other countries? So what's that first thing that you would just spit out that we need? Thank you.
You may push the button. Go ahead.
It's on? Okay. Thank you. Thank you for that. And I heard your presentation yesterday, and it was wonderful. The first thing that comes to my mind, and it's something that Noor said, is listening to patients and families, and hearing those stories and your lived experience. And then to reiterate persistence. I'm a social worker. I've, walked with people through, times when insurance, was denying things, and just, not giving up. I'm sorry to hear that your sons are without what they need. But I think really listening to the perspective of patients and families, and to Fadi's point, one way of doing things doesn't always work. Even here in the States, I think it's important for us to remember that even here in the States, we have to adapt and adjust what, the agenda that we come into conversations with to be able to listen and learn from you guys. So that's the first thing that popped into my head when you were talking.
The first thing that I thought of is
to let these individuals feel seen. Again, like someone shared, they're not numbers. These are individuals just like us. So to have them feel that they are seen in itself is just so empowering and so powerful. And it may sound simple, but truly it's not. And then one other thing I thought of right away too is teamwork. Teamwork and building that trust between the patients and the caregiver, the physicians or anyone from their team. It's so important. And honestly, because of teamwork, I'm sitting here today.
So till we get Mary to talk, I think the most important thing that comes to mind is to be sensitive to the culture that you're going to. So don't assume that what you have here, don't just assume they're going to just go there and apply it there and they're going to be happy with it. You have to listen to what their needs are, and then you have to really work. I mean, I take my team with me. I'm from Egypt originally, so I kind of know the culture. I've been out of it for a while. But teaching your team that you're taking with you the culture, that, you know, you need to listen, you need to be patient, and it's very important.
I would say equality for everybody, for all CF people, no matter where they're from the United States or another country. Yes, we have many things that other countries don't, but we need to just look at it as a CF patient and equality for anybody wherever they live in the world.
Our session today, and we are really grateful that all of you chose to come and listen to us. I think we have formed a great panel, and everybody has shared what was on their heart and what's important, and we really appreciate you being here. Thank you so much.